And we will move on to part 3 of the lecture. And I want to talk only about one parasite in this part of the lecture, and that is going to be cysticercosis. Obviously, toxoplasma is also a parasite. We already spoke about it during the portion of the lecture that dealt with infections and AIDS. And there's other things that happen all over the world, such as malaria. I've seen 2 cases in my life. It's very, very uncommon. Echinococcus in the Americas, as you know, is more common in Ecuador, Peru, northern Chile, and Bolivia. In the northern part of the continent, we almost never see it. So I do want to concentrate on cysticercosis because, as I said before, worldwide, cysticercosis is the most common parasite to affect the central nervous system. And cysticercosis will happen equally in immunocompetent or immunosuppressed patients. So its incidence is not higher in AIDS patients than what it would be in you and me. Now, the interesting thing about cysticercosis is that it spreads in a hematogenous fashion. And once it does that, 100% of the times you're going to have involvement of the brain. About 10% of patients are going to have involvement of CSF-containing spaces, ventricular system, or subarachnoid space, including the basilar cisterns. And about 1% of patients are going to have infection of the eye or the spinal cord. Spinal cord lesions are fairly nonspecific. And if you suspect that your patient has a cysticercal spinal cord lesion, the best thing to do is get a brain MR because nearly all of them are going to have brain images or a brain CT to look for calcifications. Now, cysticercosis has been divided into different stages, such as the ones that we spoke with abscess. It's actually been divided into 4 different stages, but I'd like to kind of summarize them into 3 different stages. The first one is the vesicular stage. There's no enhancement, there's no edema, and as its name implies, the parasite is going to be a fluid-filled abnormality, a vesicle of fluid. During this stage, the parasite does not produce any inflammatory or allergic reaction in the brain of the host and can live with the host. It is when the parasite begins to die and the vesicle, which generally contains the urine of the parasite, ruptures, that you have an allergic and inflammatory reaction that leads to contrast enhancement and edema. And that is what's been called the colloidal or granular stages of cysticercosis. Now, if you have cysticercosis that's disseminated all over the brain, you're going to end up with encephalitic cysticercosis with many lesions and diffuse brain edema. And it happens that if you leave the patient alone and let the parasite live its normal life, all of these parasites will eventually die and calcify, and this is what's called the nodular stage of cysticercosis. What happens is that we treat these patients to avoid the complications such as seizures, and because the parasites are all in different stages of their lives. So some of them may be being born or just growing, some of them may be dying and producing symptoms, and by treating the patients, we're going to kill the parasites at any stage of their lives, avoiding this recurrent or repetitive episodes of symptoms that the patients may have. So typical findings in cysticercosis, as you can see on the upper left-hand corner of the slide, there is white matter edema and a cystic lesion in the left temporal occipital region. It shows rim enhancement. On the flare bottom left hand of the slide, you can actually see the scolex, and on the Kiss or Fiesta image, you can clearly identify the scolex. There's a red arrow pointing to it. So if you see a cystic lesion with a nodule in the middle in an endemic region, I think that we all can very confidently suggest the diagnosis of cysticercosis. Here is a patient that was given to me by a colleague from Brazil. You can see on the upper row of images, multiple cysts with their scolex throughout the brain. Notice that there are cysts in the temporalis muscles. There are cysts in the ocular or retrobulbar fat on the left, including one of the extraocular muscles, the medial rectus. Notice on the parasagittal image, the patient has a million cysts throughout the musculature in the neck. And if you see the image of the lumbar spine, you can see parasites in the subcutaneous fat, in the psoas, paraspinal, and gluteal muscles. And on the lower right-hand corner of the slide, you can see also parasites in the muscles of the hand. So again, the implication of these slides, or this case, is that cysticercosis is a diffuse systemic disorder. Now, when it affects the cisterns, it's a racemal cysticercosis, and generally a scolex is not seen. Here you see racemal cysticercosis affecting the sylvian fissure on the right. Notice that there is enhancement on the edges of the racemose cysticerci, and that generally implies a component of inflammation and that the patients are dying, and obviously these can produce also a vasculitis resulting in infarcts. Now, we said that the majority of these lesions will calcify and they will die. The immune reaction the patient has put up to fight these things disappears, and they should not enhance. However, as you can see in this case, the top row is a T2 weighted image showing you this dark lesions. The implication of the image is that all of these lesions are dead. There's no edema and no calcification. However, on the bottom of the slide, notice that there is significant enhancement of these lesions. And let me show you a more recent case. On the bottom of the slide, labeled with arrows, you see the calcified cysticercal lesions, no surrounding edema, so we assume that they're dead. However, on the top of the slide, some of them, they've been labeled with arrows, are still enhancing. So the current thinking is that despite the fact that these lesions are dead, a constant and perhaps permanent allergic and inflammatory reaction towards them may occur by the host, and that ring enhancement may be present in a small percentage of them, maybe up to 10% of them throughout the life of the patient. So how do we get cysticercosis? Well, we've been taught not to eat undercooked pork. Undercooked pork does not give you cysticercosis. If you eat undercooked pork, you will swallow the larva, they will grow in your bowel, and you'll get an intestinal teniasis. The problem is that these people who have an intestinal teniasis, their fecal material will contaminate the water supply. Now, they use this water to irrigate vegetables, tomatoes, lettuce, things that we tend to eat without peeling them. And this water infected with the tinea will contain the eggs. We swallow the eggs. The gastric acid in our stomach dissolves the eggs. These eggs hatch and produce small larvae which will penetrate the bowel wall, and then they spread in a hematogenous fashion all over the body. And like I said, 100% of patients will get involvement of the central nervous system. So it is not eating undercooked pork, but rather drinking contaminated water or eating vegetables that have contaminated water in them. Now, as I said before, about 10% of patients will have cysticerci involving CSF-containing spaces. And in our protocol, to look for these, we always include Fiesta or KISS images. On the left hand of the slide, you can see a comparable flare and a KISS imaging. On the right hand of the slide, you can see images through the fourth ventricle. On top, the KISS or Fiesta image. On the bottom, the flare image. And notice how much better you can see the cysts on the high-resolution T2 weighted image. And let me show you the practical situation where KISS images or Fiesta images are very helpful. So here's a patient that came in with acute hydrocephalus, big ventricles, transabdominal fluid resorption, and there is the sagittal T1 weighted image on the bottom of the slide. The patient was taken to the OR, a shunt was placed, patient came back for follow-up. Here's a sagittal image, ventricles look a little bit smaller, but if you pay attention, within the fourth ventricle, there is a very little thin membrane that you were able to see on the initial study, and we missed it because in both studies, we did not do the high-resolution T2-weighted image. We call the patient back, and now you can see the cysticercosis, even with its polyps within the fourth ventricle, and also affecting other cisterns, such as the left sylvian cistern. What is the importance of this case? If the neurosurgeons would have seen the lesion within the fourth ventricle, they would have gone in and taken the lesion out of the fourth ventricle instead of putting a shunt, because now the patient is shunt dependent. Shunts will fail along the life of the patient in basically every patient. So the patient will have to come back for a revision of the shunt, where just by taking the cysticercosis out of the fourth ventricle, this situation could have been avoided. And here is another interesting case that I just saw. Here is a cysticercosis sitting in the anterior aspect of the third ventricle. The patient was going to be taken for endoscopic evacuation of this cyst. And when we did the immediate preoperative imaging of this patient, we noticed that the cyst was no longer in the third ventricle, but it had migrated into the left lateral ventricle, as you can see on the right hand of the slide. And these cysts are very pliable, and they may move one ventricle to the other one. I even seen them going from the third ventricle to the fourth, and from the fourth to the third. So the key point is to get your imaging immediately before the patient is going to be taken to the OR. And of course, everything that looks like cysticercosis is actually not cysticercosis. So to finish the lecture, I'm going to show you two slides. Here is a patient with multiple cystic lesions that appear to be in the CSF-containing spaces. They had peripheral enhancement, and they look very much like the patient that I showed you with racemal cysticercosis. But these were cystic metastases from breast carcinoma. And here's another patient, multiple cystic lesions that show no enhancement on the gadolinium T1 that's in the top center of the slide. And you can see multiple lesions throughout the cerebellum, the supratentorial areas. There's no enhancement in the cerebellar lesions, but this patient had a lung cancer, and these were cystic lesions from a lung carcinoma. So if you happen to live in an area where cysticercosis is not endemic, then you have to think about other things such as cystic metastasis to the brain.